Good afternoon. Good afternoon, everybody. Thanks for your attention. I'm Brian Smedley. I'm the director of the Health Policy Institute at the Joint Center for Political and Economic Studies. Welcome to this closing plenary for what has been, from what I understand, a very exciting and a very stimulating conference, as we knew it would be. This panel is on incentivizing quality, promoting equity in the quality improvement enterprise. So obviously there are a lot of very challenging and difficult issues, but importantly, some very significant opportunities to incorporate equity as a core principle of quality improvement efforts. We have a very distinguished panel, and we want to get right into it because, unfortunately, we've got to scoot at 4:30 and allow for the closing session. And also, Dr. Carolyn Clancy is going to need to leave at 4:15. So I'm going to go ahead and introduce our panelists, get right into some questions, and then hopefully we'll have some time for audience interaction. So that I don't stand in front of our guests, to my right is Steve Summers. Dr. Summers is president and chief executive officer of the Center for Healthcare Strategies, which he founded in 1995 with a major grant on Medicaid managed care from the Robert Wood Johnson Foundation, and his complete bio is in the package. Dr. Joseph Betancourt is director of the Disparity Solutions Center and senior scientist at the Institute for Health Policy and program director for multicultural education at the Massachusetts General Hospital. Deborah Ness, seated to his left, is president of the National Partnership for Women and Families. She has extensive background in health and public policy and a very effective advocate for women, families, and other underserved populations. Finally, last but not least, you all know Dr. Carolyn Clancy, director of the Agency for Healthcare Research and Quality. She has served previously as acting director of AHRQ and also director of the Center for Outcomes and Effectiveness Research. And again, all of their bios are in the package. Please join me in welcoming this panel. We're going to have a somewhat informal discussion, and we want to get right into it by allowing our panelists to talk from their perspectives about what are some of the key issues, challenges, and opportunities in incorporating equity in quality improvement. So we'll start with Dr. Clancy.
Well, thank you, Brian, and good afternoon, everyone. I can tell this has been a wonderful conference because almost all of my favorite people are right in this room. So. And I will also say that I heard that my colleague, Dr. Ernest Moy, did a terrific job in an earlier session, and let me just say we haven't rehearsed. So if I say anything that contradicts him, he's probably right. You know, we're coming close to releasing the 2009 annual reports on quality and disparity. So this always comes up for us because we use exactly the same measures in both reports for quality. And the good news this year is, of course, we go into much more depth in the disparities report on access. And you know, it's kind of nice to imagine that at some point in the future we might actually get to lose that part of the disparities report, just because obviously we're turning a whole new page here in Washington this week on behalf of the country, which is fantastic. But a question that comes up all the time, as many hospitals, healthcare organizations, nursing homes, you name it, are struggling with public reporting and increasing transparency of quality in healthcare, is can we also use that same structure for disparities? And we often hear that some clinicians in particular have concerns that in some way, if they see sicker patients, they might look worse, or it might give them an incentive not to see sicker patients. So oftentimes many discussions start with trying to turn around a negative, right? Can we do it in a way that's okay? So recently in Health Services Research, there was an article published where one investigator had the great idea to look at the Premier quality demo and to see if there had been a negative impact on various subgroups in that demonstration, and the short answer was no, and he did a very lovely job. So I do think there's a huge opportunity, and I know that Dr. Kalman gave a really great presentation earlier about why you need one set of measures to accomplish both aims. And in many ways, it's a kind of statistical, straightforward fact. If you are going to improve quality overall, you can make a big dent by identifying the groups at highest risk of poor quality and really focusing efforts there. Now, really focusing efforts there may involve taking on some issues that are actually a little bit beyond the doors of the healthcare system, that may involve trying to think about how do we work more effectively with community partners and so forth. I will say, though, and I'd be very interested, and I'm still interested in learning how Massachusetts and others are dealing with this. One of the big challenges is also math, right? Because all of our public reporting gets very much anchored by attribution and sample size and so forth. So either we have to dramatically increase the sample sizes for reporting, which is not impossible, and or we need to do some aggregation at a higher level. So that challenge I just wanted to highlight for folks, I think, is one that we have to keep in mind, that for one kind of quality, you're thinking about my hospital or my practice. For looking more broadly at how are we doing for different subgroups of patients, you might be thinking about my community, region, or state. This isn't because each clinical counterpart isn't necessarily concerned about the same issues. It's just that there may not be enough numbers to give people reasonable information. And finally, I think thinking about quality and equity in the same sentence, which is how we try to think about it all the time at ARC, we've always got to be focused for all consumers, families, and patients on how do we give people good information about what they can do. You know, when Kevin Shulman published his famous study with the actors portraying patients, which in my view, I believe is how we ended up getting the charge to deliver a disparities report every year, we were quite thrilled by that. When I was with him at a small press conference, the first thing a local news reporter, they always ask the tough questions, right, said was, what are you going to tell patients right now? Well, that was like really quite an awkward moment, right, because we didn't have a good answer to that question. And I think the enterprise writ large has to have some good answers to that question. So I'm very much looking forward to hearing from my colleagues up here and also in the room, so I'll stop here.
That's great, thank you. Deborah Ness, from the perspective of consumers, particularly those consumers that are falling victim to some of the inequities in our healthcare systems, what do you see as the potential for quality improvement and equity?
Okay, well, first of all, I've heard a lot of wonderful things today. And I want to say that as a consumer advocate, I want to go on record. I'm a true believer that data collection, measurement, reporting can really drive quality improvement, and that we need to use those things in ways that put improving quality at the top of the list, but also help us create the right incentives and rewards for both providers and consumers. And also, we have to use it to give consumers information that they can use to make better decisions. So I think no question that data collection, measurement, reporting are critical to moving the needle. And I couldn't help thinking about how different today's conversation was than if we had tried to have this conversation even a year or two ago, and how we've moved way past the whether we should be collecting this data to how we collect it and what's the right way. So we're no longer quibbling about some of the basics or the fact that you can't fix what you don't know is broken, and that's really good news. But at the same time, I was also very struck by how important it is that we keep in mind that it's not just about getting the data collection and the measurement and the reporting right. Because we could actually do all those things, and we could do them very well, and we could actually change provider performance and still not achieve our ultimate goal, which really is patient outcomes, better patient outcomes, and reducing disparities. That's what it's really all about, and we need to keep our eye on the prize. So when I think about that, I think there are two things. We need to pay attention to what we're measuring, and we also have to pay attention to how we use that measurement. So let me spend a minute on the what we measure, because I don't think it's a secret that the consumer community has been rabble-rousing over the last few years for better measures. We have a preponderance of clinical process quality measures. Those are important, but you've heard us all say we want more outcome measures, we want to be able to measure functional status, we want measures of coordination and care transition, we want measures of safety and even efficiency, and we want measures of patient-centeredness. And I want to pause here because I think that is a place where we do a lot more talk than walk. We all like to talk about getting to a patient-centered system. But when you look at the measures that we're all focused on, we are a long way from really using patient-centered metrics. And you just have to look no further than how we're doing on the use of patient experience surveys. We have them. They could be better, but we have them, and they're not in widespread use. And I would challenge us that it is very hard to imagine how we get to a truly patient-centered system of care if we don't figure out how to routinely solicit from patients what their experience of care is, and then use that information routinely to improve care. So we have a long ways to go on that front, and I'm hoping the conversation will be able to say some more about that. But I think to get there, there needs to be a paradigm shift. We have to get away from thinking about patient experience of care as the same as patient satisfaction, a nice thing to do, but not necessarily essential to clinical quality. And we also have to get out of the mode of thinking that providers know what patients want, or that providers would define patient-centered care the same way patients would. And we have to begin to sort of peel back the onion of patient-centeredness and realize that actually the things that patients say they want go far beyond satisfaction and really would help us get to better clinical outcomes. The last thing I want to say is that it's not just about what you measure, but how you then use the results of that measurement. And two areas I want to throw out there. One is that I think in a couple of sessions I was in today, I heard people talk about the importance of making sure that the way we use this information doesn't disadvantage those who are serving the underserved. That we need to do it in a way that provides, in addition to the measurement, the support and the resources to help with the quality improvement and the redesign of practice. That when we're doing measurement, we need to make sure we're risk adjusting in a way that takes into account the complexity of the patients that we're measuring for, and that we look at both improvement as well as attainment. From a patient perspective, when you think about how you use this information, I would throw out a few things. One, it starts with having meaningful measures in the first place. We want patients to be able to use this information in a meaningful way. The information has to be meaningful to them. Secondly, there are lots of ways to present that information to make it easier to use. Third, I would say that there has to be a supportive environment in which patients are encouraged to use that information. That means changing the culture of the interaction between patients and providers. It isn't all about just giving patients information and then thinking they're going to somehow transform into engaged players in the same old system. The system's going to have to change to support and reinforce their engagement. And then finally, to the extent that we want to use this information to incentivize behavior by consumers, I think we need to be as disciplined about getting evidence about what works and what doesn't work as we do with respect to measurement. I would submit that we need to be very serious about evidence-based benefit design, because I think the way we design those incentives could impact different populations differently. We need to understand what we're doing before we go too quickly down that road. So I'll stop there.
Great, thank you. Dr. Joe Betancourt, as head of the Disparity Solutions Center, you see a lot of innovation. You're on the cutting edge of what works and what doesn't work. But you've also been a provider for many underserved populations, so you've seen it from many perspectives. What, from your perspective, are some of the challenges and opportunities in trying to get equality in quality?
Yeah, I think, first of all, thank you for this opportunity. And it's really great to see so many friends here still at this battle, and the fact that we're still here, I guess, means that this issue hasn't gone away, so it's very important. Certainly, I feel like I'm in a very unique position because our state, I think, in certain ways has been at the vanguard of healthcare reform, but also as it relates to some of these disparities-related issues. And to go back in time a bit, we go back till right after the release of our Institute of Medicine report on equal treatment, when the mayor of Boston took this issue on and brought the major teaching hospitals together in Boston to basically develop a requirement that we all collect race and ethnicity data. So this issue became one that was no longer optional, but one that was mandatory. And I think we went through all the bumps that we talked about, but I'm in Marsha's camp of, certainly we need to move forward, and we were forced to move forward. The systems weren't perfect. We debated how many categories, how we were going to collect it, scripts, IT. But nevertheless, I think we made great progress in that regard. And I think that is the foundation, certainly, for anything related to P4P and public reporting, embedding disparities-related measures into your quality reports. So we've been fortunate, and I think that's been fortified by our healthcare reform legislation that, again, required that all hospitals statewide collect this information. So, I think there is lessons to be learned there. I can bring the perspective of a hospital that quite fortunately has leadership that is very, very committed to this issue. One being Greg Meyer, disciple of AHRQ, and Peter Slavin, our president, I think, who views the issue of disparities not as one that is an add-on or that is a marginal issue, but in fact something that is essential to quality. And in fact, after the release of the Institute of Medicine report on equal treatment, his view was we are guilty until proven innocent, as opposed to, let's take 5 years to just kind of square this away and see if we have disparities. So I'm in a very fortunate position where there's a kind of talking about perfect storms, a perfect storm of support and the right set of regulations and incentives, if you will, to push this issue forward. Very briefly, I think our experience and the experience of our city shows us that we can collect race and ethnicity data. Certainly that we can begin to do reporting, and we create a yearly disparities dashboard that stratifies as much as we can. And I think our approach was, let's just look at what we have and begin to stratify it, and we'll go from there. And it may not be perfect. Certainly the messaging is very critical because there was some angst internally to say, well, what are we going to put out there and how are our providers going to see it? How are our patients going to see it? So we did have to create some messaging and a bit of a campaign about how this is really about quality, and it's about making sure that we deliver the highest quality care for everyone. And so our interest in collecting and reporting on these issues are really based on the premise of improvement, which I think is a positive message that goes a long way. We've been able to stratify our National Hospital Core measures, our patient satisfaction data, first press Gainey, then HCAHPS. We incorporate disparities-related issues into quality rounds. We've stratified HEDIS outpatient measures. We've even gone so far this year as to try to develop sentinel disparities measures, which is to say we wanted to see where the disparities literature highlighted major issues. Pain management in the emergency room has been an issue that's been written a lot about. Wait time for renal transplantation, orbit time for bypass surgery, and try to develop measures in those areas to try to push even more forward instead of just stratifying what we have. And we've begun that process, and we did pain management in the emergency room and developed some measures this past summer. So I think you can develop those measures and you can report on them. Just to double click quickly on something you said, one of the major challenges I guess I felt personally in this issue of trying to assess patient experience is that when you look at response rates for minority populations in some of our standard patient satisfaction surveys, they're pretty paltry. And I think that relates to cultural perspectives about, is it okay for me to report back and am I going to be discriminated against, language issues, other cultural factors. And so what we've done, and I think this goes back to an earlier question around do you survey around trust, is that we, a couple of years back, did a dedicated survey of 400 patients, oversampling minorities, using the Kaiser Family Foundation's set of questions around trust to get at the patient experience, to hear from those voices that we might not ordinarily hear from, and ask them some more provocative and pressing questions related to disparities, I think, that were very important. And we're trying to sensitize our radar to bring intermediaries, interpreters, front office staff, and others to not only be our eyes and ears on the ground, but also help us get information about the patient experience, thinking about focus groups and other ways outside of just standard patient satisfaction. I'll end by saying that we also try to not end with monitoring and measurement. We very quickly try to develop interventions to address disparities that we find. We found disparities in diabetes. We found disparities in colorectal cancer screening and developed programs quickly. I'll just say, getting to the public reporting piece, we publish our equity measures on the web. So anybody could Google MGH quality and safety, and you can look at our equity report, and you'll see our information there. I think we don't know that many folks do that. The bottom line is that I think the thing that protects us a bit is that right there with what we're doing and what we've measured and the disparities we found is our improvement stories, to say we found these differences and we're committed to making a difference. And so as we think about public reporting, I think certainly messaging is going to be important, because you could publicly report about safety and somebody could say, well, that's a systems issue or a competency issue. When you're public reporting about disparities, I think people's hesitancy is to say, well, is that a racist institution or hospital? And certainly I think the messaging there needs to be very critical in how you put that out. So we could talk more. I think pay for performance has value, and there are things that are being done in our state particularly that are more foundation setting. less looking at quality clinical measures, but more about, is your hospital stratifying their quality measures by race, ethnicity? We have a Medicaid pay-for-performance program in place that sends us a 27-measure assessment that looks at our diversity of our board, diversity of our work staff, whether we have information in multiple languages. So I think that's a good example of a pay-for-performance program that's not necessarily focused on, so far at this point, how well are you doing with your diabetics, but really some of the foundation setting. I think that's where the promise is right now.
That's great. You raised a couple of points that we'll want to get back to in terms of both what we can learn from the Massachusetts experience, but also in terms of the public reporting. How do we help institutions manage that and use it in a way that can be constructive going forward? Steve Summers at the Center for Healthcare Strategies, you've looked at a number of publicly financed programs. What do you see in terms of potential in some of these programs to better incorporate equity in quality reporting?
Well, thank you very much. And Joe referred to being in the Marsha camp. For those of you who weren't here this morning, Marsha Regenstein said that she loves data, but let's get on with it. Let's get past the data and start doing something with the data. And I'd like to be in Marsha's camp too. I don't know if your tent is big enough, Marsha, but
This being a nonpartisan meeting, of course.
You can always count on Marsha for a line. And Marsha's part of the Aligning Forces for Quality program too. And Bruce Siegel and Randy Siebel, I don't know if they're here with us, but they were talking about some of the issues that I'd like to raise in a previous discussion. I'm with the Center for Healthcare Strategies, and we really worry about quality improvement and equity issues within the context primarily of Medicaid, low-income populations. And so I'm sort of bringing Medicaid into the discussion a little bit more. Medicaid really is central casting for racial and ethnic disparities issues. 50% roughly of the under 65 Medicaid beneficiaries are racially and ethnically diverse. There's also disparity on the quality side with Medicaid versus commercial. So Medicaid's a land of opportunity, essentially, for working in this field, and we do that. And then comes along healthcare reform, and you have 16 million new Medicaid beneficiaries to add to the mix. That raises some challenges. First, a lot of the primary care providers, and those are the ones we're focusing on and talking about, we call them kind of high volume, high opportunity providers that are serving large numbers of Medicaid beneficiaries, and many of whom are racially and ethnically diverse. They're under-resourced, and many of them are small practices. The sort of aha moment for us was we got some data from Michigan Medicaid and Detroit. 50% of the managed care beneficiaries in Medicaid in Detroit are in onesie-twosie doc practices for primary care, which is just sort of stunning. Blows you away. You're thinking FQHCs, where are the FQHCs, et cetera. But that was one set of numbers. And then we went out and looked at Arkansas and Philadelphia and Pennsylvania, southwestern Pennsylvania, actually, northwestern New York, Buffalo, and same kinds of numbers, 50% in small practices, under 3 providers. And some of those practices, as you go down and you visit with them, that might not even have a computer. Never mind, I mean, not even a computer for billing purposes, never mind the electronic medical record types of issues. And then you have the issue of physician payment rates on top of that. So you had the story in the New York Times the other day about Michigan and 63% of Medicare and people leaving Medicaid, physicians leaving Medicaid. So you got this sort of perfect storm, 16 million new beneficiaries, nobody providing for them. That's a problem. And so good news in healthcare reform, and I haven't read, somebody said they read the whole bill. I was kind of stunned. Who was that? Somebody said this morning that they read the whole bill, and I was very impressed. I haven't done that. But there is a section in the bill that talks about physician payment in Medicaid and getting it up to the Medicare level. That's hugely important. I think it's only for 2 years, which is disconcerting, but that is at least a start to show perhaps what can be done if you start paying them. State Medicaid agencies also have race and ethnicity data at their fingertips. Now, it's a variable quality. In some states, it's pretty good. In some states, it's not so good. But if you help them a little bit to get those data and then match it to who is seeing those beneficiaries, who are the primary care providers for those beneficiaries, you can also match it. You can match the race and ethnicity. You can match the size of their panel, their Medicaid panel. You can match quality scores, HEDIS scores, And you can begin to identify the practices that are most in need, are those that are essentially the highest opportunity practices. And we've been working with some states to do that, and states and health plans can support those practices with practice coaching, HIT coaching, nurse care management for chronic illness, et cetera. So that's a kind of support thing that can be done. Then you start thinking about P for P, and there was a discussion earlier, as I said, and there's some risks associated with pay for performance with these kinds of practices. It's kind of social Darwin thing. All the money's going to go somewhere else, and they're going to fall further behind in terms of resources. But you can pay for performance won't reward them. Well, somebody suggested, Bruce actually suggested, pay for improvement. You have to go down to kind of pay for participation with these. You have to lure them in and start working with them, and that's what some of the states that we've been working with have been doing. So I'll leave it at that, and just say that there is some opportunity to try and pay for quality, but it's going to be working with them to get them up to that place.
Sure, great. So implicit in the discussion so far has been that there are some promising examples, and part of what we want to drill down on is to get a better understanding of what works. Do we have examples of either reporting, equity provisions in the context of quality improvement, where we can say this is a model that can be scaled up? I open it up for anyone. Particularly perhaps for Dr. Clancy, since we're not going to have the benefit of your wisdom for much longer.
Well, I guess I want to make a few framing comments here. I don't know that I can point to a stunning example of success, except for the RWJ project. What was the aligning for expecting success? Thank you. That was the one I was thinking about. And as I understand it, even that involved a lot of tough conversations up front, because it really cuts to the core for many providers, whether you're talking about institutions or individuals, who truly believe that they provide the same care for everyone, because particularly docs are trained to see one patient at a time, do the very best they can, move on to the next, and it's not until they can actually see the results that they start to realize that there's a problem here. And I was keying on Steve's comments about under-resourced and no infrastructure in many, many settings. I would say even well-resourced organizations right now don't really have a very good script for the acting on reporting part yet. It's evolving, and obviously a very large organization that has got millions of people they're taking care of is in a better place to make investments in health IT and so forth. But I think we should also recognize it's kind of early days, and reporting can take on a life of its own. So I have to say, listening to Joe, I was incredibly excited both to hear the stories as well as the specific action plans, because I think if we're going to bring the public along here, the issue of fairness resonates with almost everyone, and I think that fairness has to extend to issues related to income and education and so forth, geography, but also people's stories, that they feel it, that they actually can see that we're making a difference. So I don't have a specific example, but I'm hoping that together, as we attack both quality and disparities, we can begin to build that script. It is not a routine thing. It's certainly not a paid service today to look back, to say, how are we doing, where are we dropping the ball, and so forth. And in all of my training and practice life, I can only think of two examples. One was in the emergency room as a resident, where we used to look back at where we'd messed up on x-rays. That was mostly so the radiologist didn't have to come in at night. So that had a sort of secondary benefit for them. And actually, a home care team I used to work with used to do this, because in the process of setting up a database, they actually could see where they were dropping the ball, and it became so essential they did it on a regular basis. A very poor population they were providing care to. But I think that's got to be part of the fabric of care delivery before we'll have lots of positive examples.
Mm-hmm. Yeah. Deborah?
Yeah, I just want to say that I think one of the big challenges we have is figuring out the right balance between standardization and innovation. And we need standardization for all the obvious reasons we've talked about in lots of different ways. But I was also struck by some of the different stories I heard in some of the panels about how If you point people in the right direction and you give them the right information and they have the right desire to improve, which I think most providers do, there are all sorts of creative ways to get to the end goal that we are all seeking. And in the prior session, I think Bruce was talking about the Expecting Success project, and using some facilities using that information to, for example, hone in on where to do better screening. And reaching in and sort of identifying 45-year-old African-American males for early colonoscopies, okay? Now, that's a very innovative strategy. That's a use of this information that maybe we're not thinking about. It came out of the ability to sort of blend the use of standardized data collection with enough room for innovation for those facilities to figure out what was the best way they could go about trying to improve care in their communities. It also allowed them to get beyond thinking what they could do within their walls and what they had to do in the broader community.
Yeah, and if I could just pick up on that for one moment. Two examples that do come to mind. One, some of you may recall, I think it was 2 or 3 years ago when California actually had a higher rate of mammography screening for poor women than they did for all other women. And this was very much a public health effort where, armed with good data, they knew exactly where to do outreach. And we used a similar strategy over the past couple of years with the Administration on Aging in trying to address issues related to disparities among Hispanic elders. Dr. Moy gave them drill downs with their 8 or 9 metropolitan areas with a high proportion of Latinos. He was able to actually show them where they needed to target their efforts. And again, the area agencies on aging, boots on the ground, right? These are the people who can go out and they've got neighborhood contacts and so forth. So I think particularly for chronic illness and things where patients are living with this and have to manage it in the context of their daily lives, we're going to need that kind of partnership.
Yeah, excellent. There were a couple of examples, Joe, that you mentioned out of Massachusetts where the public reporting was done in a way that could be received by consumers, by providers, by administration, hospital administration staff in a way that was non-threatening and actually very productive. Wondered if you could talk more about that. But then I also want to bring into the mix Steve's observation that we have many small practice settings where it's going to be difficult to ramp up to the kinds of things that we're talking about. So any experiences from Massachusetts in terms of the small practice providers?
On the small practice side, I can't speak to that. I think that's a nationwide challenge and issue. Certainly, we're part of a network of partners, and we have a program called PG, which is our community health providers. We haven't been able to do that much in that area, although we're trying to develop some models from what we're doing at our larger hospital. Our desire to begin by measuring and developing the disparities dashboard really, I think it took on a life of its own once the decision was made to kind of go forward, and the hesitancies, we got past the hesitancy of, well, it's not going to be perfect, and we need to make sure how we message this is done in the appropriate way, both for patients and providers. I think it really took on steam. My sense was that once people put their toes in the water and felt like, okay, this is something that we can do, it picked up momentum. And the idea of public reporting, in fact, didn't come from me. It came from our Center for Quality and Safety, where we were working closely, where they said, we're putting up our safety, we're putting up effectiveness, we're putting up our quality chasm 6 pillars, and let's put up our equity measures and just put them out there, but put up improvement stories so that people see where we're moving there. I don't know that a lot of folks have done that. I think the small lessons that we could share are that messaging is important, certainly. I think messaging as well, and we do this with our dashboard, is that these, we may not have, probably more often than not, don't have p-values on this stuff. This is kind of a guidepost for us. We're collecting information that's more than just race ethnicity. So in Massachusetts, we collect education, which is a proxy for SES, in addition to insurance status, as well as a language. So we hope to, in 2 to 3 years, be able to stratify on some of those other issues to see where is it more race, class, language, education. But certainly, I think there is this innovation piece is really, really important, because ultimately, I think we need to be interested in taking that step forward. Now, I'll just end by saying that we run a program out of our center that's called the Disparities Leadership Program, where now over the last 3 years, we've trained 50 organizations, over 80 individuals, large health plans, hospitals, health centers from across the country. And I'm amazed every year when I see the applications, when I see the types of things folks are doing, and there's several alumni here, about the innovation that's happening on the ground. And these are folks who maybe are beginning with a strategic plan or just trying to collect race ethnicity data or moving towards interventions. But we've had in the course of the last 3 years, I think, more and more chief health equity officers from hospitals come, and there was a position that when we see that, we're like, wow, the field is moving. Our sense is that there is innovation out there that we can be capturing in many, many buckets. And so the public reporting piece, I think, will take a while, certainly, but I think there are a lot of pockets of excellence that we can begin to capture and cobble together that'll give us a nice blueprint for a gradual, if not steadfast, change.
Yeah, that's excellent. Steve, you made me a bit nervous when you were speaking earlier about the fact that we're going to be enrolling about 16 million more Medicaid enrollees, but yet we still struggle with infrastructure, with a number of problems. Do you see innovation at the state level, or are there other examples of how states, or perhaps in the context of health reform, we can better prepare to address equity as part of our quality improvement efforts in Medicaid programs?
Well, I don't want to make Brian nervous. The Medicaid provision doesn't go into effect until 2014. Are you relaxing a little bit?
I'm better now.
But that's enough still to make one nervous, because that's not that far away. The thing I wanted to reinforce, I talked about small practices, and I talked about Medicaid, high-volume Medicaid providers. You know that there's this thing called meaningful use, and within Medicaid HIT, and 30% meaningful use, that is to say people are using 30% of their panel roughly is around Medicaid or publicly financed populations. And they're going to have a hard time finding people who have 30% Medicaid beneficiaries. And in fact, somebody at George Washington, Leighton Koo, once observed that if they were 30% Medicaid, they probably shouldn't be in business, because it's not possible to run a practice with rates that are too low. But what I was going to jump to is to whatever degree we can get payers and purchasers aligned, and I know that's something that is of interest to Aligning Forces. Within some of the states that we've worked with, Michigan and Pennsylvania are two states, for example, where they have Medicaid managed care plans. So Philadelphia has 3 managed care plans doing Medicaid. They're going to have 4 soon, and in Detroit, I think it's 5 or 6. We're getting the state and the multiple health plans that within which these practices are probably in most of the networks, but they're getting non-standardized information, non-standardized quality improvement. Everything is non-standardized. Get the state and the plans aligned so that they're getting the same messages from the plans and the state. And that's just within Medicaid. And if you can overlay some other purchasers, then you have an opportunity to drive some of the things that you want to drive. And so that's starting to happen in the states that I just mentioned. Some other states run what they call primary care case management programs, where they are essentially the managed care entity for their entire Medicaid population. North Carolina is getting a lot of credit these days for running a very good program with their community care networks. Oklahoma has a good enhanced primary care case management program. So they are doing some of this themselves, and they have all the Medicaid beneficiaries, but they need to align with other purchasers as well.
Yeah.
Can I just say one thing about Medicaid? Because as I mentioned, the pay-for-performance program that was part of healthcare reform, that's now in its 2nd year in Massachusetts, 2nd or 3rd year, whereby we as a hospital, as part of our participation in Medicaid, receive a tool. Now the tool's got a lot of warts. It's lumpy, and it's going to get better, we hope. But it's a little bit, it was painful initially. And this is somebody who cares deeply about disparities and wants to do well. But the tool is 27 measures, and it's built on the class standards, and it asks a lot of really tough things. And when you look at it, you say, boy, even the best of the best are going to be not so far along on this tool. That being said, I've kind of come around on the tool just from the standpoint that we get this tool, there's 27 measures, and again, there's administrative issues, organizational issues, service delivery issues, and we have to check where we are, kind of, is this something that we're in the planning stage, we've been doing it for 1 to 2 years, 3 to 4 years, and there's validation that goes with it. So it's a fairly rigorous process, albeit I think the measures can certainly be improved. But what the benefit of that is it's not a ton of money, but it has generated a lot of discussion in the hospital. It's become almost an assessment tool. It's an assessment tool by definition, but it's become an opportunity for us to now be saying, well, you know, we need to be doing a little bit more here. Or, yeah, do we have this information in multiple languages? Or, yeah, do we have good community collaborations for discharge? And we know with CHF and the MedPAC and reimbursement, that's going to become a bigger and bigger issue. You know, are we measuring diversity of our staff? All these things that I think many of us in the disparities world would aspire to, we now have to kind of report on. And for better, for worse, I think if nothing else, it generates a lot of awareness and conversations and a desire to try to be hitting on more of these cylinders. So I think that's an example of where there's a current pay-for-performance program that, if nothing else, raises awareness of the importance of equity within within a kind of a frame of quality that I think can allow for some connecting of the wires and building of systems that would allow our healthcare systems to be more responsive to the needs of diverse patient populations.
That's a great example. Carolyn, you mentioned the National Healthcare Disparities Report, which has been absolutely instrumental. When that report comes out, many of us grab it right off the web. Very valuable for telling us where we are. In particular, ARC has been able to look back and look at time trends, which has been important. One of the unstated, I think, elephants in the room is that as a result of this economic recession, I would fully expect that our health disparities are going to get wider, unfortunately. I would expect that there are many communities, low SES communities, communities of color, that unfortunately are going to see poor health status as a result of this downturn. What do you expect, and what does that present for us in the context of quality improvement efforts if providers are desperately trying to bring these populations up, improve health status, but yet because of these larger economic forces, we're potentially seeing widening gaps? How do we address that?
Well, you know, I don't think that we're going to see that in our reports for a year or two because of the data lag, particularly data that's in any way linked to payment. Someday someone will explain to me why those data are always behind, but that nonetheless they are. There is a lag there that you can't get out of. But I mean, we're clearly seeing that with CHIP already, where the additional support for CHIP hasn't really kept up with declines from the economy in a number of states. So I think it means we're going to have to redouble our efforts. And I wish there were happy news here to share, but where I think it's going to be particularly important is for kids. I mean, if you look at the demographics and distribution of various groups within kids growing up today, it's very, very different. So we've been very excited to be working with CMS and thinking about starting off with a voluntary public reporting strategy at the state level for kids on CHIP and Medicaid, which is incredibly important. And ultimately, that's got to be the same as for all kids because there's a huge amount of mobility. So I think that same infrastructure can help us target our efforts. A very vital partner for us, and I know Steve has worked with these folks as well, over the past couple of years has been Medicaid medical directors. Now, unlike Medicaid directors who are generally changed when the governor changes, these are career positions. And in some states, these individuals have been very, very strong. And I mean, leaders like their capital L, they're fantastic. And because they've created their own network as a result of some activity that we originally convened, now they've got actually a career path and mentors and others for states where people weren't exactly sure what the job was. In fact, some of them have been working with our grantees, for example, to look at the use of atypical antipsychotics in kids, which is a very, very scary story. And when they actually looked at their own data, they found some very scary things. So the economy is not going to be helpful. We know that insurance and the quality of care that you get, putting aside demographic characteristics, are unfortunately heading in the wrong direction. But I think that we're just going to have to keep pushing hard.
Mm-hmm. Yeah. Deborah, obviously the historic legislation just enacted, I know that the partnership was very active there in looking at a number of implications for the legislation for vulnerable populations, for children, people of color, women and families. What do you see? Are there any opportunities in the context of, and I'm not expecting that folks have read all of the bill, but are there opportunities that you see?
We've probably read most of it. My first reaction is that the real work is now just beginning.
Yeah.
There are just enormous possibilities. There are so many things baked into that bill that are a platform for us to now run with. And I think the real work, at least from the consumer community's point of view, we have the job now of making sure they implement these things in ways that really work for patients. And there are going to be lots of pressures to change the payment system, change the delivery system in ways that show cost savings and better value for our dollars, and that's all good. But at the end of the day, from our perspective, the real test is, does it result in better care for patients? And so that's going to mean really being in there at the nuts and bolts level and making sure, first, the right things get built into the design of these new models, that we create the right measures to hold them accountable, that we evaluate them on the right things, and the right things get brought to scale. So I think for the consumer community right now, there is an opportunity to get in there, and as we redesign the payment and delivery system, do it in a way that takes us to more patient-centered care.
Mm-hmm. Great. We're going to shortly open this up for the audience to pose questions, so let me put you on warning for that. And I think there will be some microphones going around, but before we do that, let me get back to Steve on the question of the historic healthcare reform legislation. Do you see opportunities? You mentioned at the outset that there are going to be some important implications for quality improvement efforts, and particularly for publicly funded programs. Any opportunities in the context of the legislation that we should be aware of, particularly around the implementation piece?
Well, I mentioned there's an expansion. I mentioned the payment for primary care providers. There are other things in the legislation around Medicaid for medical homes and for other payment reforms. There's also a Center on Innovation that may get into some of these areas. We just met with the guy the fellow at CMS who's going to probably be working on that. So there are some things in the legislation there. And then there's the race and ethnicity and language piece. I mentioned that Medicaid collects race and ethnicity data at enrollment, and I mentioned the variability, and Marsha Lillie-Blanton may speak to that at some point. But the variability stands to be corrected because it is all over the place, and that's a whole other area that I haven't delved into at length to figure out, what's going to be the implication for Medicaid, because Medicaid is not standardized. I asked one of the earlier speakers about, where's Medicaid data in terms of any kind of standardization, given that there are 50 states, and so it's nowhere, and it needs to be. Linda Bilheimer said it was essentially nowhere, and so that's another opportunity that may have bearing upon the discussion we're having.
Great. Okay, we have a couple of microphones, I think, floating around, and the folks who have the microphones, can you hold them up? Okay, we've got a couple people over here. Anybody want to pose a question? If not, I'm going to pose another question to Joe, and while we're doing that, you can think of any questions that you might have.
Can I just ask Steve
Sure.
a question? Steve, I've been impressed when, through the advisory committee that we convened and lots of input on the measures for kids and CHIP and Medicaid, that states are highly variable in their capacity. I mean, some states sitting around the table actually could do things that I was sort of mentally calculating what we would pay for a grant to do it. And they'd made it part of core business. Oh, we link with the infant mortality data with this and this and this. And, a number of folks had their mouths open. Do you think there's an opportunity in some way to encourage collaboration between those states who've gotten way out here and those who are further behind?
Question. You alluded earlier to the medical directors, and you were thinking of Foster Geston in New York and David Kelly in Pennsylvania and Jeff Thompson in Washington and some of the states that you might expect to be at the forefront. There was another discussion earlier about leadership, and actually the Robert Wood Johnson Foundation has invested in a Medicaid leadership program. So there are leading edge states, and what needs to happen is some of those the lessons that are being developed, or the models that are being developed by the leading edge states gets out to the other ones. But The variability and the whole question of the economy right now. I mean, Arizona, which has a very, very good program, just cut 300,000 beneficiaries from the Medicaid program and wiped out its CHIP program. And now they hope to reestablish it. But the economy is a major threat, and that economy then has great impact on the infrastructure and the capacity of the state Medicaid agencies themselves. They get hiring freezes, they get furloughs. I mean, California, there are people who are working, instead of 20 days a week, they're working 14 or 15 days a week or 16 days a week. That's not enough to get things done in a state like that. So a lot of challenges there.
That's great. Any questions from the audience? Okay, there's a question back here. If you could just state your name and briefly pose your question.
Yeah, David Mann from Maryland's Office of Minority Health and Health Disparities. At one of the earlier sessions today, some data on kind of generic quality improvement programs seemed to indicate that the improvements were better in the more advantaged subsets of the population and not moving so rapidly in the more disadvantaged segments. And one of the things that we tend to think about in our office is where the potential disparities in patient self-management capacity may impact on how outcomes evolve. Because if you think about chronic disease, it's really not managed by physicians in their offices, it's managed by patients in their homes. So I think the whole question of how can we bring quality to the point of empowering patients to deal with these complicated care plans that they get. For example, asthma and diabetes, we ask the patient, take a device, measure a physiologic parameter, interpret the result, and then change your medication regimen based on the result. That's actually a fairly complicated request for patients who didn't go to medical school. So I'm just asking kind of what ways can we bring the quality process to focus on that potential final link in getting to the improvement in outcomes that we need.
Well, I have one specific example. Again, as a result of our working with the Administration on Aging, CDC, and others in HHS, patient self-management, particularly for diabetes, emerged as a very important theme. And an outcome of that is that some work that was originally started at Stanford, and ARC had a hand in funding some of this early on, which actually finds that knowledge is not so much the important thing as is self-efficacy, the belief that what you do makes a difference. They are now retooling this program so that it can be certified by the American Diabetes Association to qualify for reimbursement for diabetic teaching under Medicare. I'm told, Mark, that CMS actually has funds set aside for this that many years don't get used because there's a shortage of certified programs. So I think that is one example of exactly the point that you're bringing up.
And if I could just add to that, I think in the legislation there will be opportunity for investment in some of the innovations around creating that capacity in local communities that small practices can link into. I think that's within the scope of the new innovation center that will get created, and I think that's very hopeful. And I also think it goes back to the point I made earlier about the need for us to think about patient-centered measures. We will increase focus on this if we pay attention to the creation of measures that actually get at whether or not practices are doing things to link people to appropriate community-based services or self-support management programs. There are ways to begin to get at measuring patient engagement and encouraging practitioners to take that more seriously.
Just add to the, excuse me, the patient related to the Stanford, their work at Oregon Health Sciences, Judy Hibbert, and patient activation measures. Some of that is now being drawn into motivational interviewing as well. We're working with both Judy and Susan Butterworth on the motivational interviewing and bringing that into Medicaid. And a lot of times people think that that may be the last place that one will go with patient activation, consumer engagement. You mentioned the Rorschach test. What does it mean? But Medicaid needs that, as much. Medicaid populations need that as much or more than any. So some of that is actually happening with those researchers as well.
And I think that there's a woeful underutilization of allied health professionals in this process, right? We know we're not going to be able to add a lot more time that I could spend with patients. But certainly, we've developed some pilot programs with coaches, building on the Promotora model, navigators and the like, where I think you have individuals who are trained and have the kind of the basic skills of quality improvement and case management, but bring a twist of cultural competence, if you will, bilingual, able to delve into cultural issues. I think expand the portfolio of questions and activities outside of the kind of traditional medical model to more public health, the public health model. And I think individuals like that can be very, very helpful. They can spend more time with patients. They can connect in different ways, and they can really help in self-management. I think these programs will definitely demonstrate a return on investment, on top of the fact that I think this provides a real employment opportunity for individuals from diverse communities who are committed to helping their fellow community members. So that's an area that's quite intriguing to me, and I think we can continue to build on that. It's tested and tried and true tools with kind of a case management or disease management on cultural competence steroids, if you will, where they're really be able to be responsive to the needs not just of those who have a high level of health literacy, speak English and the like.
Brian, just want to add one other thought. I mentioned Oklahoma before. The Medicaid director in Oklahoma, Lynn Mitchell, who's a physician, part of our Medicaid Leadership Institute, she declared at one point early in the discussion in the program that what she really wanted to work on was getting her Medicaid beneficiaries with diabetes to be able to instruct their doctors about what tests they need to have. And we said, wow, that's a great idea. And we happened to have a behavioral economist. And the behavioral economist got into discussions with the behavioral economist about how you can message and get information that will activate, that they will use in order to go into their doctor's offices and insist that they need this test or they need that test. No, we don't want that drug. And that's the kind of, she wants that kind of, she calls it comparable to detailing, drug detailing. She wants the consumers to be able to do that. That's new in Medicare. That's the first time that I've ever seen anything like that. But that's exciting, and we hope to chronicle that and get it out there so other Medicaid directors can learn from it.
And Brian, Steve highlighted something I said in an earlier session that I think makes sense to raise again here. Patient engagement means a lot of different things to different people, and I call it sort of a Rorschach test. And we can all be talking about it and actually hearing it from very different perspectives. But I find it helpful to think about patient engagement in a few different buckets. I think there's the patient engagement that's about getting patients themselves to better engage in their care, be more active, engage in managing their own conditions. There's the patient engagement that I think of more as consumerism, getting patients to use information in ways so that they make better decisions. And then there's the patient engagement, which the consumer advocacy community thinks about, which is having patients sitting at the table helping to design the innovations that we're talking about. And I think it really would make a huge difference to create a culture that invites consumers to really be in the mix of thinking about these innovations as they get created.
Great point. Any other questions? If not, let me pose, and while you're thinking about other questions, let me oh, here we go. Great.
We could just keep answering that question.
Yeah.
Hi, my name is Athol, and I'm a current intern for the Institute for eHealth Policy. And I was looking through this packet here, Center for Prevention and Health Services issue brief on eliminating racial and ethnic health disparities. And it mentions there are three types of major variables that contribute to health disparities: patient level ones, healthcare system ones, and care process level variables. It seems like we've talked a lot about patient level variables in terms of socioeconomic status, language barriers, poor health literacy. We also talked about healthcare system level variables, organizational complexity, financial complexity, geographic location, and how data can drive system changes. And I was just wondering about care process level variables, which this refers to. Physicians are human like anyone. They have shortcomings, which may include racial and ethnic biases. And I was wondering how we could go about and whether it's important to look at medical education and how we train future generations of physicians. As an entering medical student myself, if we can look at the curriculum and educate students to have a keen eye for quality improvement and be aware of these certain biases as we train students to look about changing systems and being about a culture of quality improvement.
It's a great question, and one that Joe and the Disparity Solution Center has been intimately involved in. So Joe mentioned.
Yeah, and I think one of probably the most fascinating topics that we covered when we were working on the issue on equal treatment was this whole chapter on stereotyping. And I was just a few years out of residency and began to think about how little, if anything, was taught about what the literature called non-medical factors that influence clinical decision-making. And when we delved more into this as a group in the committee of, what is done in the area of medical education vis-a-vis this issue, it's almost antithetical to what we'd want, right? We are, as clinicians, raised in an environment where we learn about decision-making, or the focus is about when we should order what test and why. We're raised to believe that we should have blinders on to personal characteristics and be the advocate for every patient. We take the Hippocratic Oath, and so we are. It should be no surprise that as clinicians, when we hear about disparities, the reaction is not me, because we're raised in a culture to believe that that's static, that stereotyping kind of clinical decision, human decision-making process is below us, that we're above that, and that's something that very quickly, we disentangled as part of our IOM report. So I'm a firm believer, and we're trying to do this at our medical school, is from day one, have them take the implicit association test. So for those of you who aren't familiar with the implicit association test, you go to, it's a website, and you're able to unveil your subconscious preferences, if you will. And it's tough. We did it with first-year medical students, and their response was, there was a lot of discomfort, because more often than not, and it's human nature, you're comfortable with people who are more like you, and difference creates discomfort, right? And so when we did it with our first years, and they came in, and of course they didn't like the findings, and then obviously what happens in this area is that then people attack the test, right? Well, that test is doing it the wrong way, and and it goes with disparities and cultural comps. Everybody wants the best, the most. When it comes to issues of race and ethnicity, I think people want the nth degree of anything. And I think around this clinical decision-making piece, there's little, if anything, done. And I take great pleasure in getting a chance to speak to first and second years to really warn them about how they will be inculcated. I refer them to Malcolm Gladwell's book, Blink, and to really try to normalize this, and to our chapter in unequal treatment that really says, this doesn't have to be about discriminating, but we all naturally stereotype, and you will hear, I guarantee these students that they will hear sometime in their training, these patients, based on any personal characteristics. These patients, they, linking to a disparities example, you really got to make sure they have a fracture before you give them pain medication, because they might be pain med seeking. The examples are, we're replete with examples like that. And I think that when we address this issue with students in that way, you're able to get people engaged. And there was a time when people said, particularly after our report, when people said, well, does that really link to decision making? And then there was Kevin Shulman's paper, which predated our report. But since then, one of my colleagues, Alex Green, showed that depending on how you score on the implicit association test, when given a case on whether you'd give somebody a clotbuster, we saw that all residents that were in that study said, I'm not biased. But then when you looked at their implicit association and you looked at how that correlated with them prescribing clotbusters for African Americans, there was a clear correlation. So to think that doesn't affect us, I think we should get past that. I'm a firm believer that we need to do more in the education of all healthcare professionals to make us understand that we're not above anything. That in fact we are susceptible to stereotypes just like anybody else. And in fact, I would argue to end that we're more susceptible, given that the research shows that stereotypes are activated the most when you're stressed under time constraints and multitasking. Mm-hmm. So, when you build that substrate, you make people see. And I'm Puerto Rican, and one of the examples I give is how I began to stereotype my Latino patients around flu shots, because so many of them were rejecting it, and I began to fall into that trap of these patients don't like the flu shot. So everybody has their own epiphany and aha moment, and I think it's very important in education as an important vehicle in that area.
Mm-hmm. That's great. Other questions?
To follow up on what you said. First year, second year residents, what about the current physicians? Are they immune to this?
Yeah, so, yeah. So I believe we certainly have a responsibility. We're focused here on training, but we certainly have a responsibility to not just say, well, if you're out there, I think there is this attitude, yeah, it's too late for those folks, and I think that that's the wrong attitude, because these are the role models, mentors, community leaders in many ways. So we shouldn't leave them behind. Certainly, I think you need to tailor your education in a way that can bring these folks to the table. There's several examples nationally of how we can engage practicing providers. I'll just say that we at Mass General used an incentive, talking about pay for performance. We used a quality incentive that we have as part of our Mass General Hospital Physician Organization, where every quarter we are incented to do things that include making sure that over 95% of our notes are in the electronic medical record, that we're e-prescribing, that we do HIPAA training. And in the third quarter of 2009, there was an incentive to do cross-cultural communication training, disparities-related training. And in 3 months, we trained 1,000 physicians, practicing physicians, faculty at Mass General Hospital in this area. I think incentives are helpful in engaging folks, but it's also how you frame the education. Because if you frame it as, you're broken, I have to fix you, people's first response is going to be, you're trying to, it's political correctness, you're making assumptions about me, which is equally detrimental. I think if we talk about quality, improving your ability to care for anybody you see regardless of their background, if we link it to evidence-based guidelines and put it in the context of clinical cases, I think we have a chance to engage folks in a more robust way than we've been able to up until now.
That's great.
Community-based organizations that really want to educate current physicians and other kinds of healthcare providers, so that they will be more sensitive to the people they provide services to. Is that something you think you can welcome? Because I know of
Certainly.
some right there in Boston that are willing to do that.
No, certainly. I think we do a lot with our residents in getting them in community settings. It's trickier with providers absent them wanting to go into those settings, and how do you set that up? But I think in physicians who've done home visits, physicians who've worked in communities, who've done international experiences on occasion, come back with a very different mind frame. And so I believe that that's a very robust opportunity, yes.
Just to comment on that, I mentioned Philadelphia earlier, and we got some data from the state and from the health plans in Philly, and it took 10 docs who were relatively similar docs, small practices, and who were serving essentially the same population, largely Medicaid, largely minority, and showed the differences in their hemoglobin A1C rates, one 45%, one 90%, and they were all over the map, and we didn't identify each. They were A, B, C, D, E. We didn't name the doc. And then you sit them in a room together, and then they start working on each other. I think that if there are doctors who can come together around an issue, maybe not embarrassing each other, because it's all about at first it's all about it's the patients who are non-compliant or not adherent. And then you start saying, well, you're all seeing the same patients or the same kinds of patients. Why is there this difference? And then you help them work through, or the docs help each other work through, why is there a difference? And that's a way of educating.
Yeah, it's great. Peer learning. Other questions? Okay, we got. Oh, I'm sorry, Neil. Apologies. Go ahead, Nicole, and then we're going to come back over to Dr. Kelman.
Okay. With the efforts, the new data collection efforts, my question relates to African Americans, Black African American group. That's the group that traditionally usually has the worst outcomes, not all the time, but across most indicators. I know there was a study in New Jersey, and they looked at Caribbean-born blacks and compared cancer rates across race and ethnicity. And someone like myself, I'm Jamaican, my cancer rate risk was more similar to a Caucasian person as compared to an African American. And I'm wondering, with all this data collection, are we going to do a better job at looking at subcultures within the community? If you talk to an anthropologist, they would say there's as many as 7 within the United States. Can we do a better job?
That's a great question, and there's an important example in Massachusetts, I believe, where the issue of looking at drilling down underneath the 5 OMB categories to get actual information on nationality, various ethnic groups. So ultimately, that's where we need to go, right, to get more precision. So I invite any of our panelists. Joe, I don't know if you have any experience with it.
In Massachusetts, we do that. So we collect subgroups. And the examples like that are replete in, you could have it in Hispanic populations, Asian American populations. We really do, what I try to tell folks is that, you need to know your local environment and understand your threshold populations, because, you have a black category that's African Americans who've been here for, hundreds of years. You have individuals of African descent who are new immigrants, and that issue came up earlier today. Individuals of African descent from the Caribbean. Same thing can be said for all these. So I think that, rolling up to OMB makes sense, but certainly in the local environment, you need to really know who your populations are, because then you tailor your interventions appropriately.
Mm-hmm. Dr. Kelman?
So I wanted to go back to something that you mentioned, Joe, about the institutional assessment, and I think it ties into Atul's question as well. One of the things that I'm always concerned about is how we're trying to do, we have this message about health equity that we're trying to teach our students and residents, and yet the big question, in New York, where I practice, is that the institutions have no real commitment to equity. And so you're training students and residents in an environment, our whole next generation of folks are being trained in an environment where it's still okay to have service patients and private patients. It's okay to have, NYU and Bellevue, where one's got 80% Medicaid patients and the other's got 12% Medicaid patients, and they're on the same block. And people see a completely segregated delivery system. They see people being sent to clinics and faculty practices, based upon their insurance and everything like that in the same environment. And then we give them 2 days of cultural competency training and expect that somehow, they're going to take that and believe that everybody's created equal. Mm-hmm. So the thing that's most fascinating to me, and I think why one of the things that you've been so successful with is these measures, these institutional measures. And I think, we haven't really talked about the institutional constructs that underlie our healthcare system much today. But I'm wondering if you could just go into a little more detail about that, because those questions about who's on your board and who do you train and what does your workforce look like and all that stuff is really about how we practice, not what we say we want to do, but what we actually do in order to create a more equitable healthcare delivery system.
Yeah, no, I mean, a lot of those come out of the class standards, and I think that they're critically important. There's no two ways about it that the informal curriculum is so powerful that we can do a lot in the classroom that is quickly undone on the wards as people see the vestiges of institutional racism and classism right there in front of them. And that's a challenge that I think is tough, and I don't have any obvious solutions. But certainly I think when we started to look at these measures that came down from the state and the class standards, it's hard because these are hard questions, and they're appropriate questions. Do you have a community board that advises you? Do you have... and so I think that they're important because what it really does is it raises awareness of, wow, we think we're doing well, but wow, let's take a peek at our board, let's take a peek at our senior leadership. Well, let's look at this service line and wow, we see that there's 2 tiers really. So I think that it is important to advance these institutional measures, but the issue for me is how they are received and what teeth they have behind them, because the class standards have been around for a while and they've been left up for self-assessment for a long time, and I think they've, in many cases they've gathered a lot of dust. This is the first time where I've seen them, have at least some incentive tied to them, and I think if nothing else, it's generating some good discussion, some hard questions, which I think are very, very important, because these institutional issues are not things that we can blow over. I mean, Michael Bird, who's a really prominent, preeminent historian, always reminded us in unequal treatment that, as you were talking about today, these disparities didn't emerge over the last 5 years. These have a long history, and these vestiges still exist today in many ways, and we shouldn't forget that.
And indeed, the phenomenon that Dr. Kelman is talking about, medical apartheid, is not old. I mean, it's not new. This is a long and deep history. We still have separate and unequal health care. So I'm wondering, Deborah, talking and linking this back to the public reporting piece, part of my hope is that with public reporting at the institutional level, there can be greater accountability. Perhaps there's potential for consumers to vote with their feet. We know in many instances people don't have that choice. what potential do you see? Can we address some of the institutional level issues through public reporting?
Well, I think public reporting can be an enormous impetus, an enormous driver, but I think it by itself isn't enough, and I also think we don't want to be using it in a punitive way. And I would prefer to see public reporting combined with a whole lot of other strategies. I've been very encouraged by working with consumer groups around the country who very much want to work together with providers to encourage the collection of this data and the public reporting of this data, not from a punitive point of view, not from a gotcha point of view, but from a we want to work together with you to try to make it better. And so I have faith that if we can figure out ways to bring the consumers and the providers together in this effort, we could actually use public reporting in a way that doesn't feel punitive, but actually just drives improvement. And it sounds like you've done some of that in Massachusetts. The other thing, though, that I'm thinking about is that there is I have some interest in us looking at whether or not the professional boards of medicine couldn't play a bigger role in some of this. I think they're beginning to do some very innovative work in trying to redefine what professionalism is and to define it in a way that would include things like ongoing, lifelong improvement and learning, elimination of disparities. And they've moved far away from the old days of, one-time exams and your grandfather for life to this idea of continuous certification that includes measurement and actually continuously pulling from your own practice, stepping back, and they take the extra step of requiring improvement plans. There's nothing we do yet in the measurement and reporting world that gets to that demonstrated improvement piece. I think there's something there we haven't yet really capitalized on. The use of the boards who are moving in the right direction and are doing this from the perspective of changing people's definition of what professionalism is and the goals that we're trying to achieve.
I just have a funny story related to that because I did my board recertification in internal medicine 2 years ago. And, so it's the first time I've taken electronic tests. So I'm going in front of a computer now. I've been used to filling in the little boxes. And so, in there I walk in the testing center. I'm getting fingerprinted and, strip searched and all this other stuff to make sure you don't cheat, all these things that they do. And I sit down and, I press that fateful button, that begin. And the first question, and my colleague is next to me, and these questions change. It's, different modules, so on and so forth. My first question on my boards was, racial and ethnic disparities in healthcare exist for the following reasons, A, B, C, D, none of the above. So, number one, I wanted to fall out of my chair because I couldn't believe what I was seeing. Number two, I couldn't believe that I got that question at all, and I got it first. And number three, I knew that I got at least one right on my boards. But I mean, that's just a highlight. I was blown away. And of course, that's scratching the surface, but I was looking behind. I was like, is this like a candid camera trick? Is somebody pulling on me? It was there, and I was very pleasantly surprised.
That's great. So there is some progress. We have time for one quick question. Barbara?
Barbara Krimgold, the director of the Kellogg Health Scholars Program. It's been hard to compare the U.S. with other countries because we've been so dissimilar in terms of our health insurance. But I understand in many countries with universal health insurance, everyone has access to primary care physicians, but the access to specialists stratifies by SES. And that reminds me also of a study like Arnie Epstein's study on kidney transplants that he said, of course, you can't have equity in black-white kidney transplants because of comorbidities and worse health generally in blacks compared to whites. So my question is, in the 5 to 10 years it takes us to implement something close to universal health insurance, what kind of pro-poor, pro-disadvantaged patient policies we have in mind or can gear up so that the the stratification by SES doesn't just become more subtle.
Any of our panelists?
Sounds like another hour and a half. That's a big question, yeah. That's what I would say.
Okay. So, we're going to have one more panel on that question. It's a great question, and I think that all of these issues tie together, of course, right? We're talking about some structural adjustments, but also measuring our progress, and that's been the point of this panel. Please join me in thanking this very distinguished panel. We're going to move ahead to our final panel, but actually I see that Dr. Lillie-Blanton is not. She'll be right back. Okay. Well, join me in thanking our great panel again. I think that it's also worth noting, again, that this panel, without the Brookings Institution support, the High Value Healthcare Project, this wouldn't have occurred. So please thank Kaylon Taylor-Clark and Mark McClellan again for their supporting this terrific program. The data collection piece can't be underestimated, of course, and there are lots of opportunities for people to engage, particularly as health reform moves forward. So I think, as all of you recognize, we all need to be watching the implementation of health reform and looking, importantly, to state examples as we move forward to have a much more robust data collection system. So shortly we're going to go into our final panel. Do we need to make any arrangements for the podium here? Okay. Great. All right, just 2 more minutes and we'll be right back with you. Folks, we're going to go into our final panel just to conclude. Folks, can I ask you to take your conversations out to the hallway so that those of us who are here can hear this final thoughts? Thank you. We're very, very honored and pleased to have Dr. Marsha Lillie-Blanton help us to wrap up this concluding talk. I probably don't need to introduce Dr. Lillie-Blanton for most of you, and her bio's in your program, but needless to say, she's provided many, many years of distinguished scholarship and leadership in the area of health disparities and health equity. So it's very, very fitting and appropriate that we have Dr. Marsha Lillie-Blanton wrap us up. Thank you, Marsha.
He got another line of work to do. Told him he was great as a moderator. He has another career path as a journalist. Well, first let me say that I'm very pleased to be a part of today's conference. And I want to thank and certainly commend the Engelberg Center for having the foresight to bring together such an incredible gathering of researchers, of practitioners, providers, of government officials, and advocates who are interested and committed and engaged in efforts to improve the quality and eliminate disparities in care. The advantage of giving closing remarks is that much of what needs to be said has already been said, of course. And of course, the disadvantage is that I'm standing in the way of you, and you're going to do whatever is your other commitment for the evening. So I'll do my best to be brief. I thought I would try to sum up some of the major points that have been said today, and just kind of echo some of what I've heard both in the plenary sessions as well as the small group sessions, and then dive a little bit deeper into some of our potential next steps. In terms of summing up today, we heard a lot about data collection efforts. And I too think that it's time for us to move to the next level, but we also have a lot more work to do in terms of data collection. And what we heard today was the importance of doing more in terms of standardizing that data. And if we aren't standardizing that data, it becomes very hard to compare across systems and across provider groups to better understand what's happening and where we are improving or where we're standing still. So I still think there's work to be done, understanding we still need to go to the next level. I was in the health IT session, so some of these are more focused on the sessions I attended. In the health IT session, there was a lot of discussion about the promise of health IT, both in collecting data as well as its use in clinical decision making. And yet we also heard that health IT is no panacea, that implementing federal meaningful use measures has many challenges, but it gives us an opportunity to then say, how do we use those systems to better improve care? And finally, I just want to talk a little bit about all the energy and the excitement that I heard today about aligning forces and what its predecessor group expecting success. I've heard Bruce talk about these. It sounds like we're about to give birth, and I think we have given birth to new models, new systems. And what's important about those is that it shows us that our system, our healthcare system, has the capacity to do what needs to be done. You know, in some respects, moving to the next level is hindered or helped by our perception of can it be done. And we have learned through those on-the-ground efforts that it can be done. And for that, I think it helps us all because it gives us confidence in our ability to move forward. So we are unquestionably moving in the right direction and can begin to learn from those efforts that are now in place. As I look forward, there are at least 3 challenges and opportunities that I'd like to talk about. The first is for us to create infrastructures across the country for developing and disseminating information on interventions, and I'll come back to each of these. The second is to talk more about what we know in terms of incentives for improving quality and eliminating disparities in the provider community. And finally, I want to talk a little bit about expanding our core. The first one, in terms of infrastructures for developing and disseminating information on interventions, we've talked a lot today about data-driven strategies. But data-driven strategies require evidence from well-designed intervention studies. And what we have been focused on much so far has been collecting data to document the problem and to monitor over time the problem. What we have a lot less of are data sources and learning laboratories to help us understand what works. What do we do to make a difference? How do we intervene effectively? And as I listened, to all of our discussions, I actually pulled a short kind of summary of some work that Marshall Chin did. And I'm just going to read from him because I think he said it better in his summary. He actually looked at cardiovascular diseases, or it was a team of people, cardiovascular diseases, diabetes, depression, and breast cancer. And the exact words, while there is an immense quality improvement literature, relatively few studies have specifically examined how to improve quality of health care for minorities, and even fewer studies have identified the reduction of health disparities as an outcome. So I think the next level of our work is not just monitoring data, but trying to look at what interventions make a difference. And while there are models in place, I think we've got to build on those models. We have to develop those infrastructures around the country. And then we have to begin to put in place, we have to disseminate that information in a timely fashion. I have learned a lot and will continue to learn a lot from the Geisingers, from the Intermountain Health Plans. But I don't assume that what I've learned from those centers are necessarily applicable across all the communities that we are focused on. The second kind of challenge and opportunity I want to talk about is how we incentivize quality improvements. 2 of the new controversial approaches that we've talked a lot about today are performance-based provider reporting and performance-based payment systems. And the question is, once again, do these initiatives help or hurt efforts to eliminate disparities, since many patients from communities of color and many low-income patients are in poor health? My view is that in the long run, they will, with some caveats, if these systems are carefully designed and the key stakeholders, both consumers and patients, are represented at the table, and they are actively engaged in the design of the tools. So for example, today we talked about maybe it's not pay for performance, maybe it's about pay for improvements. We have to begin to be at the table and talk about how do we use these tools so that we are certainly understanding the conditions that providers face, understanding the conditions that the patients face, and then using those as a way to drive improvements in our system. We have in place systems that help us understand what's happening at the national level. The National Healthcare Disparities Report we've talked about has been an incredibly important resource and tool. But we need data that's more at a local level, at a state level, at a provider level, at an organizational level that helps us better understand where the problems are and where we're making gains. And so the challenge then is to develop the reporting and the payment systems that don't result in disincentives for providers to care for some of the most vulnerable in our community. And this is important because there are considerable differences exist in the major sources of care and the major providers of care that are used by racial and ethnic groups in the United States. And this pattern, the segregation of our providers, reflects many different factors. I mean, some of it is patient preferences, some of it has to do with provider practice location decisions, and some of it just has to do with the geographic location and the segregation that exists in the U.S. But many of the providers that are located in communities of color serve a larger share of uninsured and publicly insured patients and have higher uncompensated care debt and have not been able to invest in the newest technology or don't have the same level of access to specialty providers. Some of the providers offer higher quality care and others don't. The intent is not to be an apologist for those that don't deliver the highest quality care, but to use performance-based reporting and payment systems, as I said, to promote improvements of care. The last challenge I want to talk about is just expanding beyond our nucleus. There are two issues I want to talk about, and they're related. One is about growing the core of individuals that are working on both sets of issues, and the second is to build stronger points of intersection between those people who are working on disparities and those people who are working on quality improvement. The core of the individuals and the organizations working on QI and working on disparities have by and large continued to evolve along parallel tracks with very few points of intersection. What is so important about this conference is that we were brought together. You know, we actually have sitting in the room and in our sessions people who have worked overtime in both of those areas. That doesn't happen often. And so what we've got to do is sustain what we have begun today. And the process of sustaining it, part of it takes a unifying framework so that we recognize that the issues that we have worked on in our separate corners, in our separate areas of work, actually link into one. And for those who are working on eliminating disparities, I'd argue that the unifying framework is understanding that achieving the goal of a healthcare system where care is not defined by personal characteristics such as race, ethnicity, or language is fundamentally about improving the quality of healthcare. And for those who are engaged in quality improvement efforts, I'd argue that the unifying framework is rooted in the initial IOM definition of quality that includes equitable care as one of the 6 fundamental dimensions of quality. Including equitable care routinely in QI assessments and in the interventions to improve care should actually hasten the discussions of how to operationalize the concepts. Some of the fear about how you include equity has to do with the concerns in general about how you measure it. How do you know when you've gotten to equity? How do you define equity? You know, in one of the sessions I was in today, there was a lot of discussion about, do you adjust for illness? Do you adjust for SES? In other words, do you stratify or do you do adjusted measures? I mean, there are lots of concerns about how you present the data. So I do agree that part of the problem in the quality improvement world is what is considered the best way to operationalize this concept of equity. But until we begin to do it routinely and have the questions raised to us, until we do it, until we use it to help inform it, it won't get any better. I mean, I listened to a great presentation today about the use, Dr. Kaufman's use of his data in his practice. And he, too, was someone who was just did not think that there were disparities in his system. And once he started to look at the data, he realized there were, and the next step is, what do we do about it? So using the data is the step to improving it, to understanding it, and making some headway in this merger of the two fields. I know to some extent this is fairly oversimplistic, but we've had some discussion about whether or not a rising tide lifts all boats. And I want to say that while I agree fully that we have to raise the bar, I think we have to raise the bar and close the gap. So we have to do them both, and they can be done. Because if you look over time, if we don't, we will find ourselves continuing to just raise the bar. There will be continuous improvement along both groups, but the gap will remain. Given that the U.S. is experiencing a demographic shift, both in the age and in the race ethnicity of the population, it's important for us to consider not just whether all boats are lifted, but how high each boat is lifted. In sum, we have to focus attention of the healthcare system on the performance of the whole as well as its parts. And in doing so, foster greater points of intersection between those fields who are focused on doing one part and those fields who are focused on the other. And hopefully that will help us accelerate the pace of progress in creating a healthcare system that equitably cares for all. I want to thank all of you all again for allowing me to be a part of this conference at this extraordinary point in history. And I would say that this conference itself is the beginning, is the very beginning of what I hope is a greater interaction, greater points of intersection among two fields which really have comparable goals. Thank you so much.
Thank you very much. Now, I really am standing between you and whatever it is you're going to do next, but there are two important things that I want to do before we wrap up. That's saying thanks and also talking a little bit about next steps. In terms of thanks, I want to start with Marsha. You know, the toughest job in any conference is summing up what has happened during the whole day, especially for a conference like this, where there's so many things going on, so many passionate, informed, and interesting presentations, and I think Marsha did a terrific job of closing us out. Thank you very much, Marsha. And also the afternoon panel, you know, it's a tough time to fill, but both covering the big picture and tying what you all have been doing in terms of measurement, in terms of implementing change to address disparities, tying it into what's going on with healthcare reform. I thought they did a terrific job too. And Brian, yeah, we are going to get you your own talk show. I think you did miss your calling there. The next thanks is to all of you. You all, the speakers here today, have had, I've heard lots of compliments about the presentations, and all of you who have participated in this conference. We tried to make it interactive, knowing who was coming. That was absolutely the right decision, with the breakouts, with the back and forth, having plenty of time for discussion in our presentations. You all added an extremely important set of dimensions with many insights to our discussions, and not only that, I heard a few comments like, I'm going to take this back with me to my work, and that's where we're really going to see, I think, some of the biggest differences. Because as you all pointed out repeatedly, this can be done. We can make progress on better data, better analysis, and greater impact on the frontline activities that you all are undertaking to improve care. And with healthcare reform going on now, well, there's never going to be a better opportunity to do it. So coming next, based on all these discussions, as I mentioned earlier, is we're going to be doing a white paper that's not going to be so much a summary of what happened today as it is a forward-looking piece. And Marsha started us off in that direction by talking some about where we go from here, what are the remaining challenges, but specific steps that we can take now to build on the progress today. I think Marsha's right, and I don't think you used these exact words, but we really are entering a new era right now. A number number of things have come together. As Deb mentioned, we've got measurement in a place and support for measurement in a place that's never been before. We've got the potential to lay out a path for supporting real improvements in care that not only lift all boats but close the gaps. And we've got healthcare reform that's going to make it, look, it's never going to be easy, but we're never going to have a better opportunity than we have right now. So we will be calling on you all again soon for comments on that white paper, for suggestions, but especially for your continued help and your leadership in eliminating health disparities while we're improving health in the United States. So thank you all again very much for what you all have done to get us to this point, and thank you in advance for the help in taking us beyond it. Now, I would also like to spend a moment to recognize the contributions of the people who actually made today possible. And in addition to the presenters, in addition to all of you who had such outstanding comments, I want to specifically thank our National Conference Advisory Board. It's a great group. Joe Betancourt, Helen Burston, Andrew Crichton, Romana Hasnain-Winea, Ernest Moy, Jeanette Noltenius, Ruth Perot, Bruce Siegel, and Mary Yodelman. They did a great amount of work to help us conceive of this effort and to help us put it together. So thanks to our Conference Advisory Board. And I mentioned this earlier, but it's worth repeating, the Robert Wood Johnson Foundation. We had some outside-the-box ideas for how we wanted to put together some groups that normally don't come together. They have been terrific in helping us think about filling some important gaps and working with a number of groups that, again, don't normally always get together in order to do that. So I want to thank them for their support as well. So thanks to the foundation. And a special thanks to the staff at the Engelberg Center and the High Value Healthcare Project. That's Allison Megliola, Michelle Rude, Ayadola Anisha, Aaron Wyrider, Beth Rafferty, Bryn Barnett, Larry Kokot, Joachim Roski, and Kalon Taylor Clark. Kalon, I talked about people who put this together. This was Kalon's brainchild. She thought of this approach a year and a half ago, and she and the rest of the team, they pulled it off with terrific content, terrific organization, and unbelievable timing. I mean, how did you figure this out with health reform? So thank you very much. Thank you. And so finally, we do want to hear from you. Again, there are some evaluations. If you haven't filled them out already, please take one more minute to do that. That'll help us for the future. You can leave it on the table. You can give it to one of those staff members that I just mentioned. And again, look for hearing from us again about the white paper in 6 to 8 weeks or so. We are looking forward to collaborating with you in the weeks and months to come as we continue to work to address these absolutely critical issues in healthcare reform. And just to repeat what many of our speakers have said, including Marsha, now's the time. It can be done. Let's sustain what we've begun today. Thank you all very much. Thank you.